Good morning, and thank you to the organizers for the opportunity to present today. On behalf of the CATCH study team, I'll be presenting systematic HIV testing for older children of HIV-positive adults in care. About 60% of HIV-positive children identified during the most recent Kenya AIDS Indicator Survey were previously undiagnosed. We've seen PMTCT programs scale up over the past decade, resulting in fewer new infant infections. But what about older children born before the scale-up of PMTCT systems, or infants who continue to slip through the cracks of the PMTCT cascade? For those children, there are no systems for routine pediatric HIV testing prior to symptomatic illness. Provider-initiated testing and counseling, or PITC, is recommended, but it's incompletely implemented, and it tends to preferentially test the sickest children. And we know that when children remain undiagnosed until they're symptomatic, the risk of mortality is extremely high and the benefits of ART are limited. From a testing systems perspective, offering testing to all children is relatively inefficient, as overall HIV prevalence among children in Kenya is about 1%. Routinely offering HIV testing to the children of HIV-positive adults already in care may be a more efficient strategy to optimize the limited resources that we do have available for pediatric case detection. Additionally, parents may prefer home-based testing to clinic-based testing for issues of convenience or confidentiality. And door-to-door home-based testing has been used widely in various sub-Saharan African settings and is highly acceptable and cost-effective. In the CATCH study, we aim to answer the following three questions. Does active assessment and referral for testing increase pediatric HIV testing? What is the burden of undiagnosed pediatric HIV in this population? And is home-based testing more acceptable and effective than clinic-based testing? Additionally, we're currently analyzing data to determine the barriers and facilitators to pediatric HIV testing, as well as to compare the cost-effectiveness of these two testing models. This study involves 6 HIV care clinics in urban settings in Kenya, 5 in Nairobi, and 1 in Kisumu in western Kenya, as outlined on the map. Enrollment began in November of 2013 and is ongoing and is projected to end in December of this year. We systematically asked every HIV-positive adult in care whether they had any children of unknown status. We recruited those adults with children under 12 years of unknown status, and operationalized unknown status as never having been tested for HIV or having tested negative during infancy but not having returned for confirmatory testing following the cessation of breastfeeding. Parents enrolled in the CATCH study and were given the choice of testing at home, at clinic, or not testing their children. HIV-positive children were then referred to the HIV care clinic of the parent's choice, and we followed them at 1, 3, 6, 9, and 12 months post-diagnosis. Linkage to care data is still being collected and will not be presented today. To determine the burden, the impact of active referral, we used an interrupted time series analysis comparing the 10 months before intervention to the 10 months after, controlling for temporal trends. To determine the burden of undiagnosed HIV, we estimated prevalence. And finally, to determine preference for home versus clinic-based testing, we used a one-sample test of binomial proportion and compared prevalence using chi-squared tests. For our first question, we evaluated uptake of pediatric testing before and after implementing an active referral system at our largest Nairobi site. At this site, parents have historically been able to bring their older children to a dedicated pediatric HIV testing clinic, but this was ad hoc, not systematically implemented. In collaboration with the clinic staff, our team developed an active referral system in which clinic staff aimed to assess every client and ask whether they had children of unknown status, and then refer all eligible clients to test their children. Notably, this did not require additional referral staff. During 2013, before the intervention, 3 to 4 children were tested each month. During the period in which active referral was in place, 13 to 14 children were tested per month, and after adjusting for slight increases in testing trends over time, we determined that shifting to an active referral system resulted in a highly significant, nearly 4-fold increase in the number of children tested in the same age range per month. To address our second question, we first wanted to quantify the burden of untested children. In the overall cohort, the referral staff evaluated 26,000 HIV-positive adults in care who fell into the following 4 categories. On the left, we see that about 15% of adults reported they had no children. 52% were parents who reported that they knew the status of all of their children. 27% of parents reported having children of unknown status, but had only children who were too old for our study, over age 13. But this points to a population of adolescents and young adults who are currently untested and may require tailored testing services. And finally, 5% of parents reported having children under 12 years of age who required testing, the population we'll be talking about in further slides. Taken all together, roughly a third of parents already in care had children of unknown status. All parents with children of unknown status, ages 0 through 12, were offered a referral to enroll in the CATCH study, regardless of whether or not they wanted their children tested. Over half declined referral, another 20% were eligible but did not enroll, and a final 8% scheduled testing visits but did not return to test their children despite multiple opportunities to reschedule. For those who declined referral, it's not clear whether they didn't want their children tested or did not want to enroll in the research study. For those eligible but not enrolled, the most frequent reasons cited were wanting to test their children elsewhere, having children who lived upcountry or far away, or not feeling emotionally ready to test their children. Overall, we estimated that 87% of adults with children of unknown status did not test their children with our study staff. And while some may have tested elsewhere, we weren't able to determine that in our study. This graphic does illustrate, though, the unique barriers in the older child cascade that need to be a priority for future research. Among parents who did test, 75% elected clinic-based testing over home-based testing, which is contrary to our hypothesis. However, there were more children tested per adult in the group that elected home-based testing than those who elected clinic-based testing, with an average of 1.9 children tested per adult in the home, compared to 1.3 children per adult in the clinic. 249 children were tested, of whom 7% were positive, which is a substantially higher prevalence than universal testing would reveal in the general pediatric population, suggesting that this may be a more efficient approach to case detection. The prevalence differed regionally and was as high as 15% in Kisumu, Western Kenya. 2 positive children were identified through home-based testing and 16 through clinic-based testing, with prevalence estimates of 2.5% and 9.5% respectively, a difference that showed a trend towards significance. This suggests that parents may selectively be bringing children with higher risk to clinic for testing, and this is consistent with other studies that have compared home to clinic-based testing in adults. Just 1 child was evidently ill at the time of diagnosis, and 10 out of the 18 children who tested positive were 5 years and older, with several 11 and 12-year-olds, suggesting that this testing approach may be finding those asymptomatic older children potentially born before the scale-up of PMTCT, and all of these children have linked to care. This study had a large cohort of adults and was conducted at 6 sites throughout Kenya. We systematically collected recruitment data, which enabled us to estimate important gaps in uptake that would have been missed had we focused only on the enrolled cohort. Our approach is limited in that it only applies to adults that are already engaged in care. And in Kenya, we know that about half of positive adults are aware of their status and fewer than those are engaged in care. Additionally, our study was able to recruit from several different clinics serving urban and peri-urban populations, but our results might be expected to differ in a rural setting. And finally, our study is ongoing and we don't yet have data on all participants. So in conclusion, a systematic change to active referral increased the number of children tested 4-fold, and yet most parents still did not complete testing within our study. Alternative approaches are clearly needed to motivate these parents to act promptly to test their children. Additionally, many parents had older children of unknown status who may require additional tailored testing approaches. Clinic-based testing was preferred to home-based testing, a finding which may differ at rural sites. And finally, this testing strategy identified a population with a high prevalence of HIV infection and many older asymptomatic HIV-infected children. I want to thank you all for your attention and acknowledge the CATCH study participants, team, and collaborators, as well as our funding agencies. And with that, I'd be happy to take any questions. Thank you.
Thank you. This paper is now open for questions. I see one back there.
Laura Vico, Vancouver. I may have missed this at the very beginning, but could you please comment on pre-test counseling of these families, if any has been done or if it has had any impact on outcome?
The pre-test counseling that was done for parents considering testing their children?
Yes.
Mm-hmm. All of the staff members that were engaged in testing children as part of this study were trained in the standard national protocol for pre-test and post-test counseling, which was consistent with other HIV testing services available through voluntary counseling and testing.
Thank you.
Mm-hmm.
Pablo Rojo from Madrid, Spain.
Mm-hmm.
Fantastic work, and I think it's very practical.
Thank you.
My question is, again, on that 59%, what were the reasons for not having the test? Did you question them? Because I think it's terrible. They are already engaged in follow-up clinics. They know about their status, and they don't want to test. So, can you talk about that?
Sure. In the cascade where we noted the 87% of parents who did not test their children, unfortunately, because it was a research study, those that declined referral to the study, we weren't able to talk to them directly. We did conduct in-depth interviews with parents who were considering testing, as well as collect quantitative information about the barriers and facilitators. While that analysis is still underway, the main barriers and facilitators that were coming out were that parents were concerned that their children would be positive. They were also convinced that their children couldn't possibly be positive, so these two kinds of contradicting ideas. People were very concerned about disclosure to their partners, which may have been a barrier to implementing home-based testing. Other people found a lot of barriers to actually taking the time off of work or affording the transport costs or childcare in order to have the testing visit.
You're having the home-based testing, you're going to say.
And for some people, that may have overcome that ability, but for those who couldn't take a day off of work, even a home-based testing visit may not have overcome that barrier. Mm-hmm. So, yeah, thank you.
Rashida. Yeah.
Congratulations on an absolutely brilliant study. I was wanting to find out how you deal with the issue of consent from guardians for children. Clearly that played a role. And the second thing is, what about those children who are not living with their parents? I mean, I know you focused on your starting point being biological parents, but a significant proportion do not live with their parents either because they're orphans or parents are away. I'd be very interested to know how you address that in your study.
Yeah.
Thank you.
Thank you. Those are two very important points about consent from caregivers, as well as what we did for orphans and vulnerable children. So with consent, we did get consent from the parent if it was available. We asked for permission to seek assent from the children if they were between 7 and 12 years, but that was up to parental discretion, and that was informed by our Community Advisory Board discussions, as well as a bioethics consult based in the U.S. And if the mother was not the index client, we sought to have the mother come in for testing and also give consent. If the mother was reported to be deceased or not in the picture, we did allow testing to happen with the index client of the father. For children that were under the care of index clients enrolled in our study but were not the biological children of that parent, we did test them. So that did capture some orphans and vulnerable children, as long as that index client was the caregiver. But we agree that orphans and vulnerable children are not necessarily met by this systematic testing approach and do require other targeted services.
So one last question, has to be very brief.
Thank
1
you.
minute.
Nadia Samagudu for the Institute of Human Virology, Nigeria. We recently did a study that was presented at last year's IAS where our passive HCT testing rates were 3% in children. With PITC was 8.3%, which is similar to what you're finding. But the main things that I think we need to research into is some of what you've already discussed, pre-test denial of parents about their child's HIV status. And secondly, a certain level of generally not feeling that children who look well may have HIV. And thirdly, we really, as Africans, don't have the sense of well child care or well adult care, that if the child looks fine, then there's really no need to test or to find out terrible news. So I think we need to do more qualitative studies and really dig into this and get parents who have been given several opportunities to actually pick them up and follow through. Thank you.
Okay. Thank you for the comment. I agree.